The syndrome of inappropriate hypersecretion of antidiuretic hormone occurs when vasopressin is inappropriately high relative to the serum osmolality. Normal function of ADH is to induce expression of water transport proteins in the late distal tubule and collecting ducts to increase water reabsorption. So in SIADH, ADH is released in excessive unregulated quantities, thus resulting in excess water reabsorption, creating dilutional hyponatremia. Even though water is retained in quantities greater than the body's needs, these patients will typically remain euvolemic and don't exhibit features of third spacing of fluid such as edema. This is because the kidneys can still maintain their ability to excrete salt regardless of the excess ADH that is present. As ADH signals for increased water reabsorption, the body senses the increase in extracellular volume and natriuretic mechanisms come into play, which causes increased salt excretion via the kidneys. The increased salt in the urine will osmotically attract water to be excreted, keeping the body in a euvolemic state. This increase in salt excretion also contributes to the hyponatremia seen in SIADH. SIADH can occur due to hereditary causes or secondary causes. In hereditary SIADH, there is a gain-of-function mutation in the gene for the renal V2 receptors. This locks the renal V2 receptors in a continuous active state, leading to excessive water absorption and hyponatremia, which is resistant to vasopressin receptor antagonists. Most commonly, SIADH occurs secondary to another disease process elsewhere in the body. This could be due to malignancies, pulmonary lesions, cerebral lesions, drugs, and surgery. Clinical manifestations of SIADH can be due to hyponatremia and decreased extracellular fluid osmolality. Signs and symptoms depend upon the rate and severity of hyponatremia and the degree of cerebral edema. The earliest clinical manifestations of acute hyponatremia include mild symptoms like nausea and malaise. This is seen when the serum sodium concentration falls below 125 to 130. Lower levels of sodium are associated with headache, obtundation, and seizures. Coma and respiratory arrest can also occur if the serum sodium level falls below 115 to 120. These symptoms arise due to the increased movement of water into the neurons, causing intracellular swelling, resulting in neurons to be dysfunctional. Now let's talk about how to diagnose SIADH. There is no single best test to diagnose SIADH. Patients usually present with hyponatremia with normal volume status. However, we can use the Schwartz and Bartter clinical criterion as a guide to diagnose SIADH. The Schwartz and Bartter clinical criterion is as follows. Serum sodium less than 135, serum osmolality less than 275, urine sodium greater than 40, urine osmolality greater than 100, the absence of clinical evidence of volume depletion, the absence of other causes of hyponatremia, and finally, correction of hyponatremia by fluid restriction. The tests that are done to diagnose SIADH are serum osmolality and serum sodium, and urine sodium concentration and urine osmolality. Renal function tests and random blood sugar tests are necessary to check hyperglycemia and uremia, as these are the potential causes of pseudohyponatremia. We must also rule out hypothyroidism and adrenal insufficiency before labeling a patient with SIADH, so we should do investigations like thyroid profile, serum cortisol, serum potassium bicarbonates, and chlorides. Additionally, we can also do fasting lipid profiles and liver function tests in these patients. Further tests are required to find out the underlying cause according to the patient's history. Patients with long-standing smoking history, weight loss, or pulmonary symptoms must have a chest X-ray and a CT to look for small cell lung cancer. Treatment of SIADH involves the correction and the maintenance of sodium levels and the correction of underlying abnormalities. So in patients with mild to moderate symptoms, the mainstay treatment is to restrict oral water intake. If hyponatremia is persistent, sodium chloride in the form of oral salt tablets or intravenous saline can be given. When we are correcting the sodium levels, the fluid that we are using must have an osmolality that is more than the urine osmolality. So 3% hypertonic saline is used for this purpose in patients with severe symptomatic or resistant hyponatremia. Also, the rate of correction should not be high because more rapid correction can result in osmotic demyelination of the central nervous system, leading to severe lethal complications like osmotic demyelination syndrome, causing quadriplegia. Patients presenting with severe symptoms like seizures, confusion, and delirium need urgent initial correction with hypertonic saline infusion for the first few hours rather than just doing water restriction. Loop diuretics such as furosemide can also be added to the salt tablets as it helps to decrease the urine sodium concentration. Vasopressin receptor antagonists are also available and approved for the severe persistent SIADH, and these drugs prevent ADH-mediated free water retention by antagonizing the V2 receptors and correcting the hyponatremia. Other therapies like lithium or demeclocycline are also effective in SIADH, but both drugs are nephrotoxic and they have potential side effects. Therefore, they should only be used when other therapies are failing. So, what are the complications? The potential complications include headaches, depression, tremors, muscle cramps, and memory problems. Most severe potential complications include respiratory failure, seizures, hallucinations, coma, and death. I hope you guys learned something today. And if you did, please hit the like button and comment your ideas. And subscribe to my channel for more content like this. And as always, thank you for watching. I'll see you on the next video.